Okay, I know we've already talked about this and this being a summation, but when we're talking about maintain nutritional status, I just wanted to add to this that when we have babies that are using up more energy trying to eat and they spend long hours, like if you start feeding them at 6 and they don't get through eating till 6:30, if they spend more than 15-20 minutes nursing down their required amount of calories, they're over expenditures. And a lot of times we just think, well, if we can get all this down, then that would be great. But, it doesn't matter the time. But it does matter the time. So we need to make sure that if they're not able, if we can't set up a scheduled feeding for them, we should set them up for a scheduling of every 3 hours. That way they have 3 hours of rest in between feedings. Let them eat a certain amount of time and then stop trying to feed them after a certain amount of time, such as about 20 minutes. But if we have them on scheduled 3-hour feeds, we will remember to feed them at a certain time. The babies don't have to cry to tell you they are hungry. We can also add things into their formula or breast milk to increase their calories. If they're not able to do a good enough intake with a bottle and doing their formula, then we need to go to NGOG feeds. A lot of babies have to have NGOG feeds. They can nurse until they get to a certain point, a certain time, and then the rest of it can be fed down through an NG tube. If you put down an NG tube, it doesn't interfere with their sucking. So, doing that 3-hour schedule feeds is a good thing to do for babies. Alright, hypoxemia. This one is, refers to the arterial oxygen tension that's less than normal. So, hypoxia, of course, is when we have a reduction in tissue oxygenation. And then cyanosis is what results from that. So when we start seeing cyanosis, we know we're not getting very good tissue perfusion. So over time, it can develop into polycythemia, which y'all should know that those are increased numbers of red blood cells. We've talked about polycythemia before. Polycythemia increases the viscosity of the blood. And it crowds out those clotting factors. And then the clubbing, and that does the same thing in adults as it does in children. So, you have that thickening, flattening of the tips of the fingers and the toes. Again, you may see some hypercyanotic spells, which we also refer to as TET spells, basically because it's often seen with tetralogy of Fallot, and we've already talked about that. So, those are some things that you may actually see. They occur most often in the mornings. Sometimes they're preceded by crying and other stressful procedures they may be having done. So just remember that it places a child at risk for neurological complications as well, so they could have a stroke, CVA. Cyanosis in the newborn could be a result of anything. So we really have to do to distinguish between the two. We can actually do a hyperoxia test. So they actually have started doing a testing on these things. Diagnostic, of course, our therapeutic management is basically the same with those that have the ductus arteriosus. We give them prostaglandin E to keep it from closing. It causes vasodilation, and so it's going to keep that patent ductus patent. And they've been lifesavers for a lot of these infants because it helps them at least get some oxygenation before us until we can get them stabilized. This usually occurs if the ductus is quite large, is very large. The tet spills, we've already talked about, you need to make sure what position to put them in. There is a box in your book on page 842 that tells you how to treat these hypersinotic spells. Most people don't have IV and morphine available. When they're, you're out in the parking lot, somebody's child goes into that. So, but you can do putting them in that knee chest. Dehydration, of course, again, is the most important thing you're going to be doing um, most important prevention you're going to be doing, because you really need to monitor them accurately. Of course, we still have to watch for overhydration as well, so we really have to make sure that we are um, treating them and telling parents that if they have increased activity, if temperature outside is increased, if they're running a fever, anything that might cause them to use more fluid in their body than what they normally do with a lot of sweating, whatever, then they need to have an increase in the fluids that they take in. So, what are we going to do in our nursing care with congenital heart defect? Well, it's certainly a shock to the family, and it's very alarming. So we really need to help our family become adjusted to the disorder. We have to know enough about the disorder to be able to explain it and what may follow and what can come of it. There's some disorders we can't do anything about, but most of our congenital heart diseases, if they are um, recognized in time, there's something that can be done for that. And so all of the family needs to be educated, even the siblings, how to manage their child at home. There's a lot of things that we need to be sure that we teach them about the symptoms of the cardiac condition, what symptoms will show worsening, how they might know about the development of congestive heart failure. Definitely need to know about those things, that we need to make sure that the family know about those. Um, Sometimes breastfeeding may be a little bit difficult for them to do, but there's certainly no reason why they can't pump and feed their child. Um, and definitely they need to be sure that they have oxygen available at home in case they need it. They need to know how to use it. They need to be taught that if they have extra activity, they may need to increase their oxygen during that level of activity and then decrease it when they're not as active. Um, they may have some developmental delays. All these things we need to be sure we're educating them and helping them manage their kid at home. We've already talked about the catheterization, what we should do, our post-operative care. Definitely need to be sure we're watching for those clinical manifestations that I told you about. And box 25-7 has the complications after cardiac surgery that you can look at. Some of the things that can be a big issue, so you want to be sure that you look over that. You want to be sure that you know the signs of renal failure, because you need to know that babies should be outputting 1 milliliter per kilogram per hour. You don't just say 30 mils per hour. It has to be exact to what their kilogram is. So they should be 1 milliliter per kilogram per hour. If it's less than that, then that's signs of renal failure. So you need to be watching out for that. And of course, you got to provide their rest. You got to make sure that they're have a progressive schedule of activities planned, so that they start out slow and work their way up to where they're not their heart can take the stress that's on there. And of course, we're going to plan for their emotional support as well. Babies will regress, toddlers will regress, so we want to make sure that we are looking out for that. And on page 848 are the topics to include in discharge teaching, so be sure that you look at that as well. And I think that should finish that little PowerPoint. Now let's go to the acquired cardio disorders. We just got through talking about congenital cardiac disorders. Now we're going to talk about these acquired cardio disorders. The bacterial infective endocarditis can usually be prevented by using prophylactic antibiotics in a child anytime there's dental work or any invasive procedure needed by using a prophylactic antibiotic. It can occur from anything from any side of local infections, and it can be very painful for the patient. They are on box 25-8, it tells you all the clinical manifestations of infective endocarditis and characteristic findings you're going to have on there. So usually it's based, the diagnosis is going to be based on that. So microorganisms grow on that endocardium, and deposits of fibrin occur, and it makes it the heart, it can't function as it should. So what are we going to do for these? Of course, the prevention we just talked about, but how we're going to treat this is that with long-term parenteral drugs, so they may, it's going to be so long-term they may have to have an IV at home. We want to make sure that child knows about the IV infusion, what we're going to be doing, be sure we're watching for our side effects of antibiotics, and so forth. Rheumatic fever is an autoimmune reaction to a streptococcal infection. It is not a contagious infection. However, strep is contagious, and kids at school can give it to each other very quickly. Children who complain of sore throat should always be checked for strep. Although, you know, if your child has rheumatic fever, someone that gets around your child is not going to catch rheumatic fever because it is not contagious. It is just the autoimmune reaction to the strep infection that they get from possibly being exposed to someone with strep infection. Salicylates and penicillin are usually what we give these patients with rheumatic fever. The aspirin should be continued once they go home if he develops polyarthritis. These swollen, painful joints usually are manifest themselves with rheumatic fevers. Very, very painful, and aspirin is about the only thing that you should be giving them to that. Now, if your patient had developed a virus, then you would not want to give aspirin because of the possibility of Reye's syndrome. But it's the drug of choice that we usually give for those polyarthritis that occurs with the rheumatic fever. The hyperlipidemia, we are seeing a lot of this in children these days simply because of a lot of obesity, because we eat a lot of fast foods. I'm not going to go into detail about hyperlipidemia. That is something that you can kind of watch for. They're talking about testing it in the population on a whole at school. But the main thing that we know about hyperlipidemia is that we basically need to be sure that we have a change in lifestyle modifications. We try to make sure that we are following a diet that is low in fat or high in the right types of fat. So we want to be sure that we're studying out for that. And a lot of people make their own lipids and cholesterol, so it's really kind of hard sometimes to control it because of that. The cardiac dysrhythmias, yeah, no, I think Ms. Candler went over a lot of the dysrhythmias, sinus tachycardia. Those are things that Ms. Candler went over in your EKG, so I'm not going to go over that a whole lot. Pulmonary artery hypertension is it's a rare disorder, but it is a bad thing for neonatal to get. We don't really understand why it happens. It's progressive and it's eventually fatal, and we don't know how to cure it. It usually starts showing up in the neonatal period, and they usually don't live very long. Prognosis is very poor. We have tried a few things, but basically we don't know what causes it. The cardiomyopathy, of course, is when the myocardium, the cardiac muscle's ability to contract, is impaired. And I think that, cardiomyopathy in a child is a lot like, has the symptoms a lot like they do with the adults. They use beta blockers, the same as they do in adults. Of course, we have to do a lot of very careful monitoring with these children with that. They continue to have all these dysrhythmias. About the only cure with our vasodilating drugs doesn't work. We may have to seek out for a heart transplant with cardiomyopathy. Heart transplant, we have heart transplant is our last ditch effort. It's kind of hard to find a heart for transplant because most parents can't bring themselves to donate their infant's heart. If they died of SIDS or they died of some other heart-wrenching thing, you're just not prepared to lose your child, much less donate their organs. So they're very hard to come by, but it is one of the treatment options for those that have worsening CHF and limited life expectancy. So the orthotopic heart transplant refers to removing the recipient's own heart and implanting a new heart. The heterotopic heart transplant, when you put a heart over the owner's heart and kind of piggyback it in. So they go through a very careful cardiac evaluation to determine, because these hearts are so difficult to get, they're very selective in what child will get the heart transplant. So the waiting list is, the mortality for that is very high, especially in those smaller children. And hopefully they will actually invent a artificial heart someday that will be able to be used until one is available for these children. Usually the first 6 months to 1 year after the transplant are the most intense because of the risk of complications and rejection. So, and then of course, taking care of this heart transplant, we have to be sure that we're monitoring for those signs of rejections, infections, and the side effect of those immunosuppressant medications. The family has to be taught how to not let their child around patients who have any contagious type disease, so they make sure that they stay compliant with their medications. So if they're not compliant with their medications, then their rejection of their heart, even if it's been 10 years, can occur. Our vascular dysfunctions. These are all dysfunctions that we see in our vessels. Of course, hypertension, systemic hypertension, we know is usually between one of our major problems with adults. and essential hypertension has no identifying cause, and the secondary does have a cause. So hypertension in children is usually having a systolic or diastolic blood pressure that consistently falls at or over the 95th percentile. I'm not going to expect you to know all that. The thing about the hypertension is usually it is due to a structural anomaly such as a cardiac defect. Most common, the secondary is renal disease, followed by the types of neurological disorders that may occur because of a congenital heart defect. Kawasaki disease. It is an acute systemic vasculitis of unknown cause. So we don't really know what causes it. It's seen in every race. The acute disease is self-limited, but 20% of these children are going to develop some type of coronary artery dilation or aneurysm. Infants less than a year old are most seriously affected by it. So basically, there is an acute phase and a subacute phase. The acute phase is where there's an abrupt onset of high fever, unresponsive to antibiotics and antipyretics. Symptoms come and go. Fever is persistent throughout. The child is usually very irritable, very, very irritable. Then the subacute phase is going to begin when the fever resolves and all the clinical signs have disappeared. At this point, they're at the greatest risk for developing those coronary aneurysms. And then they have a convalescence when all of them have clinical signs have resolved, but all the lab values are not normal. So the phase is complete when all the lab values are back to normal. So there's a diagnostic criteria for Kawasaki on page 859, box 2511. So be sure you look at that. Kawasaki, of course, has been known to the long-term complications are the artery aneurysms. The thing we need to do, the thing I want you to know is that with Kawasaki disease, our main treatment for them are high doses IV gamma-globulin along with the salicylate therapy. So we want to have aspirin and IV gamma-globulin. Always twist my tongue on that one. Aspirin is given during the time that we're trying to control fever. And then, of course, if they continue to have the polyarthritis afterwards. Our prognosis, of course, is that most of them will recover fully, unless, of course, we have some of those cardiovascular complications. The best thing, of course, is early diagnosis and prevention of those cardiac symptoms. So we must monitor their cardiac system carefully, make sure that they do not get dehydrated, assess them frequently for all those signs of congestive heart failure. We're basically, our nursing care is going to be focused on the symptomatic relief, which is to minimize skin discomfort, cool cloths, unscented lotions, soft loose clothing. Mouth care is very important during that acute phase. Their irritability is just way off the record, and it's very hard to deal with them. So you may have to provide parents with some away time. One thing you need to really watch for in Kawasaki disease is not really related to the disease itself, but related to the medication, because we're giving them aspirin to help deal with the inflammation of the polyarthritis, and it is severe and it lasts a long time. We need to be watching these kids for GI bleeding because of the aspirin intake that they have. And then we have shock, and we have different types of shock. Circulatory failure. Usually with a child, they're going to go into respiratory arrest before they go into cardiac arrest. And there's different types of shock that we're looking at. And there's a box on 2512 that you can go and read. And there's a box that has their clinical manifestations. So there's all different types of shock that we can look at. Anaphylactic shock is really our worst type of shock that we're looking at as far as having a terrible allergic reaction. And the best outcome for our patients would be if we recognize early on that they're having an anaphylactic shock, and make sure that we are giving them what they need and protecting their airway, because when they're most of the time their airway is what goes the first time. Then our septic shock is a systemic inflammatory response, and it's just like it would be with the adult. And you've already learned all those things about septic shock about adult, so it's basically the same for a child. Toxic shock syndrome, usually we only see this when it's related to a tampon, but I guess this is going to include our children that are of age to have to start their menstrual cycle. And remember to always remove the cause, and then we can treat it. We need to be teaching them general hygiene measures such as good hand washing. And I believe that is going to complete my cardiac pediatric.